Okay, so let's discuss the questions of dermatology, and I'm sure that everybody was very happy as I got the messages from all my students that in dermatology all the questions they were from our notes. So I think it was a big relief for me also because uh, I like when there was the first half of the like the exam, I got mixed reviews from the students, but like when I heard about the dermatology questions, I think it were they were like very expected questions from all the topics which we have covered in our classes. So let's start with them. I just want a quick thumbs up from all of you if you can hear me, if my audio is fine. Now let's go to the next question. Oh, sorry, the first question. The first question which I got from my student is the treatment of male partner is needed in which of the following condition? I just want my students to correct me, or if there is any more details given in the question, just let me know. The question which I got was that the male partner is treated in which of the following condition? So this is actually a question from STD topic. And in STD, if you remember, when we were reading this topic, I told you that in almost all the STDs, we need to treat the partners, right? We always need to give the treatment, the same treatment kit or the STD kit is given to the partner also. But there is an exception to it. Please remember that there are three STDs where the partner treatment is not given, where the male partner, if the female is the patient, then the male partner, and if the male is the patient, the female partner, we do not treat in three conditions. One is candidiasis, second is herpes genitalis, and third is bacterial vaginosis. So from that topic, this question came, and the answer to this question is the answer of this question is option number 3, that is trichomoniasis. Please remember, trichomoniasis, which occurs due to Trichomonas vaginalis, it is an exclusive STD. You have to treat the partner of these females or these males because it only transfer from one person to another due to sexual intercourse. So male partner treatment is required for trichomoniasis. Now, why not in candida? Because you know that candida, it can occur due to other conditions also. For example, immunosuppressed female or individual, immunocompromised patient. Second, diabetes. In females who take prolonged antibiotic because of change in the flora, you tend to get the fungal infection, the candidal infection. So candida need not be 100% STD, and that is why we do not treat the male partners in all the cases. Second is bacterial vaginosis. If you remember, bacterial vaginosis, the main cause was decrease in the lactobacillus count, decrease in lactic acid, and because of this, the pH of vagina rises. When the pH becomes basic, less acidic, it becomes suitable for the growth of multiple organisms, and these organisms stimulates or triggers the epithelial cells to produce more discharge. This is known as bacterial vaginosis. Even in herpes genitalis, please remember, herpes has a tendency to recur without sexual intercourse. So, need not be preceded by a sexual intercourse. If a person is affected by herpes, he or she can get recurrent infections without re-exposure. So, please remember, in Candida herpes and bacterial vaginosis, we do not need to give the partner treatment. In trichomoniasis, we treat the partner always. So, the answer of this question is option number 3. Can I get a quick thumbs up from all of you if this is clear? I think it's an easy question which we got. The next question is this. I'm not sure about the exact picture, but what I got from the student is that there was a picture of vagina with some rough lesions like this. So I just need, from everyone, I just need a quick thumbs up if this were the exact image of this, if this is the image, or if there is any other clinical history given in the question. So what I got from the student is they have given that we have such lesions, which is condyloma acuminata or genital wart. Now, genital wart is actually HPV 6 and 11 infection, the human papilloma virus 6 and 11. Now, the next thing which you have to note in this is a pregnant female. This is a pregnant female. Please remember, normally genital wart or condyloma acuminata, we give the we give the immunomodulator drugs like imiquimod. We give podophyllin, which is a plant resin which causes mitotic arrest. But please remember, in pregnancy, imiquimod, 5-FU, podophyllin, they are all contraindicated. You cannot give this because they are teratogenic. During pregnancy, the best option is cryotherapy, where we apply liquid nitrogen. It's a very cold, minus 192 to 196 degrees centigrade liquid nitrogen. It is applied on the affected part, and that causes necrosis and exfoliation of the genital ward. So please remember, my students, the correct answer of this question is option number 1. Can I get a quick thumbs up from all of you? So please remember, this was the image. I don't know whether you got the exact image or not. And the history which was told to me by the students were that the patient was a pregnant female. So pregnant female, the first option is cryotherapy. You can even give trichloroacetic acid. You can even give trichloroacetic acid, which is also known as TCA. That is also safe during pregnancy. But never give 5-FU or imiquimod, which is teratogenic. So this was the second question which we got from dermatology part. Now the next is, we had a question which says that a patient with purple papules on the wrist and elbow since 2 months, what is the treatment of choice? Now here students told me that there was one more P which was given, and that was plain topped lesion. I'm not very sure. Can you tell me whether we had a clinical image with this question, or this is the only language given? Anybody can help me with this question? I think even with this much of history that a patient has a purple papule present on the flexural area, that is on the wrist and the elbow, since 2 months, this is a very classical description of lichen planus. And why I'm saying that this is lichen planus, what are the classical 5 P's of lichen planus? So you all know that we have a purple plain topped, we have a polygonal, purple plain topped, polygonal, pruritic papule. So I'm not sure whether they have given you the history of itching or not. Just want my students to please add whether the history of itching was given or not. But this was the question, and when you know that the diagnosis is lichen planus, please remember the treatment of choice is topical corticosteroid. For lichen planus, the first or the treatment choice is topical steroids. Only when we are not able to control the lichen planus with topical steroids, or when the lichen planus is extensive, eruptive type, then we choose the systemic drugs, either systemic steroids or other immunosuppressive, steroid uh, like steroid, we can give some other immunosuppressive drugs like methotrexate, azathioprine, etc. But that is only for the widespread lichen planus or erosive eruptive lichen planus. For these kind of lesion, for small sized limited area, we only give topical corticosteroid. So for this question, the correct answer is option number 1. Now the next question which I got from my student is AMSL criteria is seen in. So please remember, I think it's a very easy question to get. And those who know this, AMSL criteria is actually used for bacterial vaginosis. Can you tell me what are the four criteria, what are the components which are included in the AMSL criteria? So please remember, my students, there are 4 things. This is for the diagnosis of bacterial vaginosis. First, the patient has profuse white vaginal discharge. That is the first point. The second important feature is the pH of the vagina is more than 4.5. Third is that it is foul smelling. So there is a test which we do. It is known as amine test or whiff test. Amine test or whiff test. So what you do, you take the vaginal discharge, you put little bit of KOH in it, and when you put the KOH, what happens? The bacteria which are present in the vaginal discharge, it converts the KOH into amine. This is known as amine test. And when this amine is produced, it is very foul smelling. So a gush of foul smell comes out. So this is known as a whiff test. So amine test or whiff test. And the fourth is presence of clue cells. At least 20% of the vaginal epithelial cells should be the clue cells. What are the clue cells? You have the vaginal epithelial cells, which is full of bacteria on its surface, studded with the bacteria on the surface. So these are the 4 points, and the diagnosis, the answer is bacterial vaginosis. AMSL criteria is used in the patient of bacterial vaginosis. Now coming to the next question. So we had a lot of questions from dermatology, like 10 questions from such a short subject. I'm very happy, and all the questions from our notes. So I think those who were there in my classes, especially the DFX sessions and the last FMG sessions, everything was discussed in our class. So this was, I think, a very simple question, although I could not get the other option. This was an image given. You can see a hyperpigmented plaque. Usually they are asymptomatic, but sometimes even slight itching can be seen. Whenever you have such plaque on the flexures like axilla groin and they're asking you about the Woods lamp examination, can you tell me what can be the diagnosis? Anyone, Manoj, Manya, what can be the diagnosis here? Very nice. The diagnosis here is erythrasma. And what is the causative agent? What is the causative agent of erythrasma? It is Corynebacteria minutissimum. Corynebacteria minutissimum. Please remember, students, Corynebacteria minutissimum is the causative agent for erythrasma. Now, when you see it under the wood lamp examination, you see a very characteristic coral red appearance or coral pink appearance. This is a frequently asked question. INICET, Neet PG, and now in FMG also we are seeing the same question. So now I think my students have understood the importance of PYQs. Whatever exam you are giving, try to do the recent at least 3 to 4 year PYQ of all the other exams. This is a direct question from the recent INICET. Also, we had this question in Neet PG. So the answer of this question is coral red appearance or coral pink appearance, which is the Woods lamp finding. Now there was another question, and the question was Bubos are seen in. Can anybody tell me what is Bubo? What do you mean by Bubo? Bubo means painful enlargement of the lymph node. Painful enlargement of the lymph node. And usually these terms or this word is used for the painful enlargement of the inguinal lymph nodes, because this is usually this word is used with respect to the sexually transmitted disorder. So this is actually a bubo, which is the painful enlargement of the inguinal lymph node. Now I just got three options here, and among the options the best answer is lymphogranuloma venereum. The causative agent of lymphogranuloma venereum is Chlamydia trachomatis L1, L1, L2, L3, which is the causative agent for LGV. Now, what is the history in LGV patient? They get a very transient painless ulcer on their genitalia, which is self-healed. It heals like in 24 hours only. So, patient usually do not come to a doctor with the genital ulcer. But what happens after 1 to 2 weeks or maybe 3 weeks of the sexual exposure, patient develops very, very painful, multiple enlarged lymph node with or without discharging sinuses. This is known as bubo. So whenever you get this word, the LGV comes into your mind. In syphilis, please remember there is painless lymph node enlargement. In syphilis, you have painless lymph node enlargement. While in granuloma inguinale, you get no lymph node enlargement. You do not have any lymph node enlargement. Now, can you tell me, students, in granuloma inguinale patients or in donovanosis patients, sometimes you get painful enlargement of the soft tissue on the groin. What is the name given to that condition? Painful enlargement of the soft tissue in the groin of a patient of donovanosis, that is known as pseudo bubo. Okay, so pseudo bubo is a feature of granuloma inguinale, while bubo, which is the painful enlargement of the lymph node, among these options, it is seen in the patient of LGV, that is lymphogranuloma venereum. Now moving to the next question. Now here, what I got from my student is there was a history. We had a patient who had history of thorn prick while working in his garden. The lesion spread linearly up till the shoulder. So I am not sure what were the other options given, whether the image was given or not. But whenever you see the linear spread of the disease, it means that the disease is spreading through the lymphatics. Now, can you tell me, can you think of an infection which usually occurs after the thorn prick injury and it spreads in a linear direction? Anybody can think of a diagnosis here? Manoj, Manya, and other students who are live, can you tell me what can be the diagnosis here? So this could be a patient of subcutaneous fungal infection, which is known as sporotrichosis. You know that in sporotrichosis, Sporothrix shanki, it enters the lymphatics and it's spread linearly through the lymphatics. So here they are not asking you about the causative organism. They're just asking you that in this, the patient has a linear lesion. So what type of lesion is this? This is actually a lymphangitis, which occurs maybe due to a subcutaneous or a deep fungal infection. So for this question, the answer becomes option number 3. And if you remember in our recent classes, I told you that the subcutaneous fungus, it's a very high probability question. And now here we got the question from this. So please remember the answer is option number 3. The next question is, how are the margins of basal cell carcinoma? What are the margins? This is again a very simple question, a direct repeat. You got the clinical image based question from the basal cell carcinoma in your last FMG exam. In this question, in this year, instead of giving you the image based question or the clinical case scenario based question, they are asking you the question on the clinical morphology of the basal cell carcinoma. Please remember, in the BCC patient, first patient develops nodule with telangiectasia, and soon this nodule will ulcerate with a very classical rolled out beaded margin. And what do you call this? Anyone, what do you call this ulcer? This ulcer with rolled out beaded margin, this is known as a, anyone, what is the name of this ulcer? Very nice. It is known as rodent ulcer. So please remember, in the patient of basal cell carcinoma, very classically, you see an ulcer above the line joining the angle of mouth and the tragus somewhere here. And this is your rolled out beaded margin of basal cell carcinoma. Can I get a quick thumbs up from all of you? So punched out, no. Sloping, no. It is the rolled out beaded margin, which is the answer from the margins of basal cell carcinoma. Now, there was one more question. I could not get the exact language of the question, but I would request all of you, if you want to add anything to this question. The question was, a patient with painless ulcer with scarring at the center present on the shoulder. Now, in this question, something which is striking the diagnosis is this. Okay? The patient has a ulcer or a annular plaque, which is very quiet. Please remember, in cutaneous tuberculosis, usually you do not see much inflammation. These are the cold lesions which has active margins and scarring at the center. So this is a very classical lupus vulgaris. Whenever you get a question with scarring anywhere in the plaque and they're mentioning that it is painless, no sign of inflammation, always think of cutaneous tuberculosis. So here in this question, I think it's very easy to answer, and that is lupus vulgaris, which is the most common type of cutaneous tuberculosis. So painless ulcer with scarring at the center of the plaque present on the shoulder. So this is a patient of cutaneous tuberculosis. Please remember, lupus vulgaris is very common on the extensors. So shoulders, buttocks, these are the common site for development of cutaneous tuberculosis. Now, these were some of the questions, again repeating for all those who have joined just now. So very quickly, I'm repeating, we got almost 9 to 10 questions from dermatology. The first question was, treatment of male partner needed in which of the following condition? I told you that in trichomoniasis, you always have to treat the partners. So the answer becomes option number 3. The second question we got was this, a patient of erythrasma, what will be the Woods lamp finding? The answer becomes coral red appearance. The third question was from the genital wart or condyloma lata in a pregnant female on the vagina. So please remember, in pregnancy, 5-FU, imiquimod, podophyllin, they are contraindicated. The best treatment available to us is cryotherapy, or you can even give trichloroacetic acid, which is safe in a pregnant female. The next question which we got was Emsel's criteria seen in. What is the answer? Emsel's criteria is seen in bacterial vaginosis. And what are the 4 points under this? Profuse discharge, pH more than 4.5, amine test positivity, and clue cell, which are the vaginal epithelial cells with bacteria on the surface more than 20%. Then we had a question from lichen planus. In lichen planus, the treatment of choice is topical steroids, because it is the first mode of therapy. If we are not able to control with topical therapy, then we have to go to systemic. Bubo, which is the painful enlargement of the lymph node, is seen in a patient of lymphogranuloma venereum. Whenever you have thorn prick injury in a garden, most commonly subcutaneous fungus, and this is actually a question from sporotrichosis where you have a lymphatic spread. Then there was a question from cutaneous tuberculosis, scarring. Wherever you see scarring, first think of cutaneous TB. And the next question or the last question is a patient with a ulcer, which is basal cell carcinoma ulcer. What type of margins you see? The answer is rolled out beaded. Now there is one more question. Actually, I could not find the exact detail of that question, but many of my students told me that there was a question from leprosy topic. So anybody can help me with that question. We can discuss it here. Anybody can tell me what was the exact question which we got from the leprosy topic? Students told me that there was a question with some nodules on the trunk of the patient, and they have given the options of borderline leprosy, tuberculoid leprosy, or lepromatous leprosy. I've not got that exact question, and that is I've not included that question in my discussion. So those who see my class later on, I would request you to please write that question in the comment section so that I can just read it and I can make these questions better. Anything which you find missing from these questions, whether it is image or not, please try to add it. Please try to write it in the comment section. So thank you all of you. I hope everybody have enjoyed the dermatology question, and please remember everything came from our notes, from the DAMS notes. So DAMS is the gold standard for all the exams.